We want to take a moment here to welcome everybody. Before we get started, we did want to make sure that everybody is aware that next week we do have a special session, an extended session, which is going to be on human trafficking, training for healthcare professionals and support staff. That session will actually start at 12:15 next week, and this does meet the TMB requirements. We just want to make sure everybody was aware of that for next week. Next slide.
Hold on. I'm not so sure what's going on here.
There we go. So for today, this is the Family Medicine Grand Rounds for February 9th. Your activity code for today is 100-87617. If you are looking to get your CME credit, please make sure that you do that before midnight tonight. So keep that in mind. Next slide. There is a new system if you haven't already been using it. You just need to text your email address to the phone number listed. And then after that, you'll make sure to text attend, and the activity code for today is listed there. Again, I'll put it in the chat box here as well in just a moment. But if you have any questions or trouble with that, please feel free to reach out either to the CME office or to me as well. Next slide. We want to take a moment also to remind everybody to please keep your microphone muted as we begin our presentation. Also, if you would remain attentive and engaged, and at the very end of the session, I will be putting in the chat box the evaluation form. If you guys could please help us complete those evaluations for our speakers, we really appreciate that. And as far as questions today, if you do have any questions throughout the presentation, please feel free to put those in the chat box, and we'll take a look at those as we get towards the end of the session. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AHEC, and our mission statement is there for you. Next slide. CME transcripts are available if you visit the CME website. You can print and view your transcript. Their email address is listed there, and also the website. But if you have any questions, please feel free to contact them, or you can reach out to me as well. Next slide. Those CME transcripts are necessary for you to also claim if you are an AAFP member and you want to claim credit through the AAFP. You will need that transcript, so please keep that in mind. But if you have any questions, the AAFP, you can reach out to them, or you can reach out to me as well. Next slide. So we also we want to make sure that we mentioned that our grand rounds, we try to make sure that we are meeting these core competencies. So you can see that those are listed here. Next slide. And Dr. Avery has no financial relationships with ineligible companies to disclose. Next slide. So she is going to be presenting to us today on the topic weight bias, understanding and addressing weight bias in healthcare. So Dr. Avery, I'll let you go ahead and start.
Good afternoon, everyone. I hope you can hear me. I'm Richel Avery. I'm a primary care physician here at the MARC. I'm also running the medical weight management program here at the MARC as well. So my talk today is about something sensitive and something that is not talked about a lot in medical circles. However, I believe that calling attention to it is important in being able to care for our patients holistically and with sensitivity as their primary care physician. This is not to point fingers or assign blame, but to bring light to certain barriers in the care of our patients. But in so doing, it can be painful to some individuals. So these are the objectives for my presentation. Define weight bias and contextualize in primary care, define and apply the multifactorial etiology of obesity, discuss prevalence and significance of weight stigma in healthcare settings, and grasp the impact of weight bias in health outcomes and identify ways of mitigating weight bias in healthcare settings. So the term weight bias, weight stigma, and weight prejudice have been used interchangeably to refer to negative attitudes and discrimination toward individuals based on their body weight. Weight stigma plays a role in everyday life, including work, school, and healthcare settings. It remains a common form of prejudice in our society and is rarely challenged. Weight bias can affect provider-patient interactions and interfere with clinicians' delivery of care for patients with overweight and obesity. In treating this patient population, it is important for health professionals to become aware of weight bias and be prepared to effectively address this issue in healthcare. So these are the three types of weight bias. There we have structural, interpersonal, and intrapersonal. Structural weight bias focuses on social forces and institutions, including mass media portrayals of individuals with obesity and differential access to goods, services, and opportunities based on weight. For example, studies have reported negative consequences of weight bias on quality of healthcare. Interpersonal weight bias refers to prejudice and discrimination occurring within dyadic and small group interactions, while intrapersonal weight bias refers to the stigmatized group's emotional, cognitive, and behavioral reactions to negative messages about their own abilities and intrinsic worth. So why does weight bias exist? Let's examine this. Let's look at the causes of obesity. Weight bias stems from beliefs that people are responsible for their own weight and only fail to lose weight because of poor self-discipline or a lack of willpower. Stigma and shame will motivate people to lose weight. So that's the belief. Weight bias also exists because our culture sanctions its overt expression. It values thinness and perpetuates societal messages that obesity is the mark of a defective person. It blames the victim rather than addressing environmental conditions that cause obesity, and allows the media to portray obese individuals in a biased negative way. So weight bias is more likely to be expressed when individuals with obesity are blamed for their weight because of factors such as overeating or sedentary behavior. Perceptions about the causes of obesity may contribute to weight stigma and bias. Assumptions that obesity can be prevented by self-control, that individual non-compliance explains failure at weight loss, and that obesity is caused by emotional problems are all examples of attitudes that contribute to negative bias. Research suggests that beliefs about the causality and stability of obesity are also important factors contributing to negative attitudes. For example, studies show that individuals affected by obesity are more likely to be stigmatized if their overweight condition is perceived to be caused by controllable factors compared to uncontrollable factors, overeating versus a thyroid condition, and if obesity is perceived to be a condition of personal choice versus a serious health condition. So research suggests that providers may attribute obesity to behavioral factors rather than other uncontrollable factors, which can exacerbate weight bias in healthcare. So in this case, there are other causes of obesity, not just lack of self-discipline. We have genetics, age, metabolic and endocrine dysfunctions, low access to affordable healthy foods, medications causing weight gain, sleep deprivation, marketing of unhealthy foods. Becoming aware of the complex and uncontrollable factors contributing to obesity, such as biology, genetics, and environment, can help mitigate weight bias. By acknowledging that significant causes of obesity is biologic, genetic, and environmental, it increases understanding for providers and for patients. It lessens self-blame, and it increases self-efficacy for weight loss. And furthermore, by sharing information about the complexity of obesity with patients, providers can help patients with obesity in their weight management efforts. Weight bias can occur in multiple forms and from different health professionals, and can be expressed in both subtle and overt ways. Weight bias can be expressed as negative weight-based assumptions that obesity is an issue of self-discipline, stereotypes about individuals with obesity, lazy, lack of willpower, judgments that patients with obesity are non-compliant with treatment. Insensitive language about excess body weight, referring to a patient as fat, expressing insensitive jokes that place individuals with obesity as the target of humor or ridicule. Medical equipments that are too small to be functional for patients with obesity, like patient gowns, examining tables, blood pressure cuffs, speculum, scales. Being weighed in a sensitive experience for many patients with overweight and obesity. Some patients may even avoid medical care because they do not want to be weighed. And making negative comments or facial gestures while weighing patients can lead to embarrassment and shame. Medical examination and waiting rooms can be unwelcoming to patients with obesity. So common reasons include negative attitudes by office staff, waiting room chairs that are too small, and reading materials that stigmatize weight. Providers may incorrectly assume that patients with obesity have lower motivation for health behavior changes, poorer treatment compliance, and poorer adherence to medications compared to thinner patients. And consequently, providers may spend less time in appointments educating patients and avoid discussion about weight-related health. In a study of family physicians' practices and attitudes regarding care of extremely obese patients, it was found that there is a high prevalence of negative attitudes toward patients who have obesity. For example, almost 80% of the responders reported that patients frequently or almost always lack discipline, and 52% felt patients lacked motivation to lose weight and lacked willpower, and 25% of the respondents reported patients lacked motivation as well. And so it is very common among physicians. Physicians are common sources of stigma, and in a study that surveyed more than 2,400 adult women about their experiences of weight bias, 69% of respondents reported that physicians were a source of weight bias, and 52% reported they had been stigmatized by a doctor on multiple occasions. So doctors were the second most frequent sources of bias reported, out of a list of more than 20 possible sources of weight stigma. Who among you have had a patient who came back to you after you refer that patient to an ortho doctor for knee pain, and the doctor told the patient to lose weight? This is correct. Weight loss is is something that can help the patient. It may just be one part of the treatment, but that's all that the patient hears. I became frustrated when a doctor disregarded what I was telling him because he had already made up his mind that obesity was at the root of all my problems. With patients with obesity, doctors too often cannot see past the weight. So in nurses, this occurs as well. Studies of self-reported attitudes among nurses indicate that 31% would prefer not to care for individuals affected by obesity. 24% agreed that individuals affected by obesity repulsed them. 12% would prefer not to touch individuals affected by obesity. Strong words and painful to hear. How would you feel if you have a family member who has obesity and you bring them to the hospital and admitted? In psychologists, in studies comparing beliefs about individuals affected by obesity versus average weight individuals, psychologists ascribe the following attributes to clients affected by obesity. There's more pathology, more diagnosis, more severe psychological symptoms, more negative attributes, and worse prognosis and treatment. Although patients with obesity frequently identify their primary care provider as their source of information for weight management, research demonstrates that physicians' attitudes may influence the quality of care for these patients. For instance, studies indicate that providers fail to document obesity in patients' charts, avoid discussions about weight loss, spend less time providing health education, and underutilized practices that promote lifestyle changes, like referrals to nutritionists. As a consequence of weight bias, there is poor patient-provider relationship, leading to poor lack of trust, rapport, and communication with patients, decreased use of preventive health services, decreased understanding and adherence to medical regimens, low overall patient satisfaction, poorer control of hemoglobin A1C levels among patients with diabetes. Consequences for healthcare utilization. And in a study, adults with overweight and obesity were asked, if your doctor described your weight in a way that makes you feel stigmatized, how would you react? 42% said, I feel bad about myself. Some said, I would be upset, embarrassed. I would seek a new doctor. And others would even avoid future doctor appointments. Thus, poor communication and perceived stigma in medical settings may impede access to preventive care for obese patients. Weight stigma may also partially explain why many physicians fail to counsel these patients about their weight. Patients who have obesity, who do receive medical counseling, however, have more realistic perceptions of their weight, increased desire to lose weight, and more recent attempts at weight loss, providing even further evidence as to why stigma reduction in healthcare sector is crucial to the health of persons with obesity. It is believed that shaming individuals with obesity is good for them. It encourages them. This is a myth. Shaming patients with obesity into losing weight will make them successful. The opposite is actually true. It is important to highlight, in the face of commonly held perceptions, that weight stigmatization may be helpful in providing incentive and motivation to obese individuals to lose weight or engage in healthier eating and exercise behaviors. The existing research to date instead suggests that weight stigmatization is an unlikely motivator for weight loss and may instead lead to unhealthy behaviors that reinforce obesity and impair weight loss efforts. Based on the present evidence, weight stigmatization seems to pose considerable harm for emotional well-being and health behaviors, and should not be considered an appropriate or effective tool to promote public health. In a recent study called Eating and Exercise-Related Correlates of Weight Stigma, which is a multinational investigation, it was found that there were 13,996 adults who reported on their personal experiences of weight stigma and health, including eating behaviors, attitudes toward exercise, and perceived stress. The results show that those who had experienced weight stigma reported engaging in more eating to cope, gym avoidance, and self-monitoring behaviors, as well as higher levels of stress and reduced eating self-efficacy. So how do we address weight bias? People with obesity frequently feel judged, ashamed, and blamed about their body size. It is important that the healthcare environment be a setting where patients are respected regardless of their body size and can feel comfortable to ask questions, not only about weight management, but a full spectrum of wellness issues. Increasing awareness of personal attitudes about body weight is an important first step in understanding and reducing weight bias. Even the most enlightened, intelligent, and well-intentioned professionals may harbor some bias, often in subtle ways that they are unaware of. This IAT, or implicit association test, requires the ability to distinguish faces of people who have obesity and people who are thin, It often reveals an automatic preference for small people relative to people with obesity. So I would like to invite you to do this test. It is for free. Maybe later on, I can put this in the chat box so you can actually click on it. And you just click on wish to proceed, and at the bottom, then choose weight IAT. It also has other IATs, racism is there as well, and several other things. But I would like to invite you to it takes about 10 minutes to do it. But it is enlightening. So let's identify our own assumptions and answer these questions. How do I feel when I work with patients of different body size? Do I make assumptions regarding a person's character, intelligence, abilities, health status, or behaviors based only on their weight? What stereotypes do I have about persons with obesity? How do my patients affected by obesity feel when they leave my office? Do they feel confident and empowered or otherwise? One of the most important strategies to reduce weight bias or prejudice that can unintentionally be communicated to patients is to identify our own personal assumptions and attitudes about weight. One of the most prevalent areas where weight bias is perceived is in language. Very often we see news stories or articles referring to individuals as obese. By using obese, we dehumanize the individuals affected by this disease. People first language recognizes the potential hazards of referring to or labeling individuals by their disease. Thus, patient who is overweight or has obesity or patient with overweight or obesity are preferred over obese patients. At our clinic here, MAs and LVNs refer to our patients as the weight loss patients of Dr. Avery and not the obese patients. So these are terms that are encouraged and terms that are not, that are discouraged. As primary care physicians, how can we help our patients? How do we approach our patients who have overweight or obesity? Do we just ignore it if they don't mention it? The more important step is to start the conversation. It is also important that we ask properly. The first step is to ask. It is important that we ask our patients permission to discuss weight and explore readiness to change. For example, you ask, would it be all right if we discuss your weight? Use sensitive, non-judgmental manner and tone. Next, assess. Assess obesity, class and stage, assess for risks and root causes. Psychiatric causes can be addictions, depression, insomnia, trauma they may have in the past. Assess for osteoarthritis, chronic pain. Assess for metabolic issues, diabetes, hypertension, fatty liver. Assess for socioeconomic issues, disability, unemployment, income, insurance. Third, advise. Advise on obesity risks, benefits of weight loss, and therapeutic options. Focus on improved health and well-being, not on size or appearance. Fourth, agree on health outcomes and goals. Establish realistic, achievable goals, like 5 to 10% of weight loss. But this has to come from the patient. It cannot come from you. It has to be something that both of you had agreed on and agree on a treatment plan as well. Last, assist in accessing providers, educational resources, referrals to specialists or dietitians, bariatric surgeons if needed. Healthcare office environment are also important. Clinicians and staff should avoid hurtful comments, jokes, or being otherwise disrespectful, as patients with obesity may be ashamed or embarrassed about their weight. So positive office space includes sturdy, armless chairs, wide chairs with arms or firm sofas in waiting rooms, extra wide doors, sturdy wide exam tables that avoid or prevent tipping, Tables, chairs, toilet seats should sustain higher body weights, extra large gowns, reading materials in the waiting room that focus on healthy habits rather than appearance of being thin. There's also appropriate medical devices like large blood pressure cuffs, large vaginal specula, weight scales that accommodate patients who have more than 400 pounds. Weight scales should optimally be located in a private area. This scale is the scale from our clinic here. It can accommodate patients up to 600 pounds. I currently weigh my patients in the room, so it is private. Wider doorways and extra large gowns. Wider seats or seats without arms so they don't get stuck there. Finally, as primary care physicians, we build relationships with our patients. Our patients come to us because they trust us. Our relationship should be sensitive, empathetic, productive, and positive interactions. They should empower patients to make positive health behavior changes. Let me tell you a true story. During my last year of residency at UT, we put together a grant proposal for childhood obesity, which was accepted. I think Dr. Katterndall can remember that. So after I finished and started working at the Mark, I was rearing to go and help my patients. I would see patients for well child visits. And of course, I would show them and their parents the growth chart as part of the visit. And then I would address their weight. After that, I had several complaints. I had a parent telling me that her 15-year-old daughter cried for a whole month after her visit with me and would not go to school. The visit was so traumatic for her. The after-visit summary that I handed to her and her parent read childhood obesity in big, bold letters. My medical director at that time, who was Dr. Gillard, had to sit me down and talk about my language. I had the best of intentions then. I was overzealous in trying to help my patients. But in that case, did I help her? No, I actually drove her away. We are in the business of helping patients. We need to know how to communicate that. Productive and positive discussions with patients about weight-related health will be counterproductive and harmful if bias or blame is present. Addressing the topic of weight with sensitivity will improve provider-patient communication and help empower patients to make positive health behavior changes. If there is anyone who would like to share their experience, you are more than welcome to. I'm quite towards the end of my presentation, so I would like to invite anyone in the audience if they would like to share their experience.
I have an experience. Can y'all hear me okay?
Yes, I can hear you, but it's a little bit choppy.
So working in the Well Child Clinic, I feel like has been the most eye-opening in like how sensitive we have to be with our language. Because your story reminded me, I had a 15-year-old, we were talking about her being above the 95th percentile in BMI, and her parents started to mention that they recently started a weight loss plan for the dad so that he could undergo surgery. And so when I did like the one-on-one talk, I just wanted to re-emphasize to her that it's not about like reaching a certain number on the scale or anything, but just like feeling better, being like healthy overall is for like your health, not necessarily for aesthetics. Because her parents were kind of mentioning like, yeah, you know, we're a big family and it just kind of runs in our family. And so I was trying to like normalize the conversation without it seeming like me as like a thin appearing physician was trying to like, you know, chastise them. But it was tricky. And we talked about it with our behavioral health consultants about ways to use our language differently. So I do appreciate this talk because it helps to reiterate those things.
Thank you so much, Dr. Aldridge. Is that, yes. So thank you so much for sharing that. Yes, it is very tricky and difficult because, but I think you did a very good job in trying to focus on health changes, on focusing it on how it can help her health or improve her improve how she feels, and not on the numbers or how it would look or how she would look. Thank you. Anyone else?
I did have one comment, excuse me.
Yes.
I just thank you for talking about this topic, because I find that a lot of medical professionals in general tend not to be overweight or obese. And that's just more common statistically. And as an obese medical professional, I cannot tell you, every single time that I go to the doctor, regardless of my training and regardless of what I'm there for, they talk about my weight. Even if it's not something that I bring up or is anything related to what I'm there for, every single time they talk about my weight. And I think it's something that we don't really realize, that we see that number in Epic that pops up in red, and we think that it's an important thing to talk about, but it is really alienating. Like, I know that I'm a heavy person, and if I'm there for whatever I'm there for and it's totally unrelated, it does feel like I'm being singled out about something that is like a more of a demographic factor than anything, because it doesn't have warrant on my health. And so I think it's a really important topic, just like it is for any of the demographic things that we have bias about. And so it's really nice to hear this as a formal presentation, because I don't think I ever heard this during medical school.
Thank you so much, Dr. DeSerto or Carmela, for sharing that. I know it's a little bit, when I started putting together this presentation, I knew that it's going to be a little bit sensitive, and I didn't want to, so what I was trying to remind myself was, this presentation, I don't want it to sound like I'm calling out people, but I'm actually bringing it out. So it's like, I'm not going to call out, but I need to call out, because one of the things is that if we ignore it and if we let it pass, and we're not calling it out, then we're perpetuating the issue. And I'm sorry that you felt singled out in those meetings or visits with other people. But it's very true, and it can be alienating. And so calling it out and a little bit of change in how we deal or communicate with our patients goes a long way. Thank you again for sharing that.
Dr. Avery, I just wanted to echo sentiments about appreciating this talk today. I think I've had the opportunity to do a lot of research in this area and work in a couple different weight management clinics, and think this is a really incredibly important topic as we think about our patient care. I think a couple pieces to add on. I think you spoke about some of these a little bit, but weight bias is one of our last socially acceptable forms of bias, which I think can really complicate this picture as compared to other forms of bias. And because of that, I think the role of internalized stigma in our patients can really come out in our care. And we can actually inadvertently reinforce it when we have a patient coming in, blaming themselves, feeling responsible, saying they need to make all these changes. And I think as providers, we get excited when patients talk about wanting to make changes, but also kind of listening for where this is coming from, seeing if they're having compassion towards themselves, building that relationship with their body and with food in a different way. So just really being mindful of that. I think as well, I appreciate using the weight IAT. I actually used that in my dissertation. And something I found was that I tried to find a one-time intervention to help reduce bias in healthcare providers. And the one-time intervention actually wasn't effective. And I think one of my big takeaways from that is this is an ongoing process to reduce our own bias and stigma, not only with patients with higher weight, but also our patients with other marginalized identities, that we really need to be doing work ongoing and reflecting ongoing and thinking about too the intersectionality of identities, because it's not just someone's weight, it can be other identities they hold. So just some thoughts, but I wanted to thank you again for this topic.
Well, thank you. I think it sounds that you've thought about it a lot and you've studied it. So yes, it is, there's a lot of nuance to it, even if when you are trying to push or encourage patients to do this, and at the same time, there may be some other issues, underlying issues that it's not, that's not addressed, or if you're pushing so much for this and then there's the message is not being delivered properly. So thank you again for sharing. So let me, so if I'm gonna proceed to this, so these are resources that anyone can get into. There's a obesity action coalition. I am a member of it, and anyone can be a member of it. Even patients can be a member of it, and they have a lot of resources for patients and for doctors and other health professionals as well that you can use in your practice. The University of Connecticut Rudd Center for Food Policy and Obesity also has a bunch of resources that anyone can use, and I used it a lot for this presentation as well. These are my references. And with that, I thank you for your patience. Thank you for spending your lunchtime with me.
Thank you so much, Dr. Avery. I did put in the survey, the implicit bias survey link there as well, if anybody was interested in taking that, as well as the feedback for Dr. Avery, if you guys could help us out with that. But if there are no more questions, we can go ahead and thank you everybody for joining us. And thank you so much, Dr. Avery.
Thank you. Bye-bye.